I'd like to begin this podcast by acknowledging the Yagara and the Turrbal people as the traditional custodians of Meanjin, the lands on which our podcast is recorded. We pay our respects to elders past, present, and emerging.
Hello, Academy Associates. Thanks for choosing to listen to the BodyTrack Academy podcasts, where our aim is to bring clinical research to real-life clinical practice. For further learning opportunities, why not access our educational webinars? To access these, click on the link in the show notes. To further keep up to date with what we offer, why not join our Academy mailing list where you'll receive exclusive content, discounts on webinars, and more. Again, you'll find a link in the show notes. Today on the podcast, we have another special guest and a good friend of mine, Rob Walsh from all the way over in the UK. Rob, welcome to the BodyTrack Academy podcast.
Thanks for having me on, Dan. Excited to be here.
So Rob, first, what time is it over in the UK at the moment?
Mate, it's 10 past 7 in the morning. It's another lovely grey day in the UK. It's stereotypical.
Awesome.
Had a nice wet summer to start with.
Fantastic. Great commitment to the pod, Rob. Glad that you can rise up nice and early to do this with ourselves and for our listeners as well. So thought we'd jump into it. Let's go through a bit of an introduction of yourself. What's your career, kind of where you work, patients that you see, and going from there. And then we'll get into our topic from that.
Yeah, fantastic. Thanks, mate. So, as you said, yeah, we go way back. Part of that was starting off with our undergrad, which was exercise physiology. So I'm an exercise physiologist as well by background. Went into physio shortly after that. Worked in private practice for a couple of years, working with musculoskeletal work cover, sideline rugby league work. And then went over to the UK in 2019. Original plan was just to be here for about a couple of years and travel and have fun, work while I was here. 5 years later, I'm still here. Work in the NHS. So I went from private to public and seeing a whole range of patients. So we're a secondary care service. So we get referrals straight from our orthopedic consultants, rheumatology consultants, And we'll see a whole range from everywhere from post-op shoulder pain, first-time dislocations, right through to chronic shoulder pain. And this spreads to all areas of the body.
Excellent. Now, with that, you mentioned shoulder pain, and that is going to be the topic of discussion today. Now, I've picked your brain many times about shoulder pain, even through undergrad when we were going through as ex-phys. But the reason I wanted to bring you on is to get your wealth of experience from a physiotherapy point of view and having that blend of ex-phys as well. So very excited to talk about that in this podcast today. So we're going to talk generally about, general shoulder pain and more seeing from your perspective how you see them. And then I'll ask at the end what the role of ex-phys is within that as well. So before we go into it, any stats that you have on shoulder pain for us from your perspective as a physiotherapist, Rob?
Yes, I think it's an incredibly common problem. So from what's called the NICE guidelines in the UK, so the National Institute of Clinical Excellence, it's like the NHMRC in Australia, the equivalent here. Approximately 1% of adults will present with new shoulder pain annually every year. And the lifetime prevalence is upwards of about 67% may develop shoulder pain. So it's incredibly common, and mostly in those that have a physical occupation and obviously engage in physical activity. And one stat that I find very interesting, and it's something that I educate with my patients quite a lot, is that diabetes and shoulder pain is very closely linked. So if you have diabetes, you're at a 4 to 7 increased risk of developing frozen shoulder. and also chronic rotator cuff related shoulder pain.
Yeah, and look, to put it in clinical perspective and practice as well, we run type 2 diabetes classes here at Bodytrack, and we do have clients coming who have got either undiagnosed or idiopathic kind of shoulder pain, but most likely is probably presenting towards a sort of a frozen shoulder at times as well. So it's not just a stat that we have there; it's reality as well, and having that high increased risk. On that too, today's topic being shoulder pain. Is it something that generally interests you? Is it something that you do see quite a lot coming through the hospital system, or why the topic of shoulder pain today?
Yeah, I think it's an incredibly interesting area and can be a very complex area. So like the shoulder, where it's located, it's very close to the neck. So it has a lot of cross play with regards to nerve pain relating from the neck, musculoskeletal, ligamentous, joint related pain from the neck. It's often a common site for referral from other areas such as visceral organs, and can be a sign of more sinister pathologies such as neuritis type conditions, cancers, malignancies, metastases from primary sites such as lung cancer, prostate cancer as well. So there's a whole range of conditions that you need to consider other than just muscles, ligaments, bones.
Yeah,
and it's pretty debilitating as well. It can put people out of work. There's a lot of lost work time for this in the UK and Australia. It can have an effect on people's mental health as well as physical health. And it's quite a common area of chronic pain development. So a very complex area and very rewarding to help when you can help people work through this.
Yeah, for sure. And what are some of the common cases that you see in hospital as well? Is there anything that's coming in and that you're treating quite frequently, more than the others, or is it quite an array of different presentations with shoulder pain?
Yeah, the most common one, I think by far, would be what's called this rotator cuff related shoulder pain. So it's a new term that's becoming the more preferred term. It used to be called shoulder impingement syndrome.
Yep.
So we now know from the updated evidence that term impingement is not particularly correct for a couple of reasons. One, because, so I guess going into what shoulder impingement used to be described as when you elevate the arm, the space between the acromion and the rotator cuff and the humeral head is reduced, and you get a lot of friction and then pain and wearing down, progressive tearing of rotator cuff. So we now know that it's not particularly the case, because a lot of the tears that they see on scan actually happen on the side of the humeral head, which wouldn't make sense from an impingement point of view.
Right.
But we also know that imaging healthy adults, up to 50% of people impinge on the acromion and don't have pain. So that correlation between mechanical impingement and the development of shoulder pain isn't quite there.
Yeah, that's quite interesting, actually. I wouldn't have thought that would be up to that kind of high percentage as well. So I guess it just shows again, and we won't go down too much of a rabbit hole here, but what a scan necessarily shows doesn't always, correlate to dysfunctional pain that someone might be in.
Absolutely, yeah. With scans, it's around about the same percentage of things like rotator cuff tears that are present in the asymptomatic population that don't have any conditions.
Yeah, interesting. So let's focus a little bit more on that rotator cuff, and if we can go back over through just a general overview, a quick shoot at the anatomy there and stuff, so listeners can have that kind of visual experience as well.
So shoulders, again, it's a complex, very mobile joint, so it relies on about 80% of muscular control for its stability. It's designed to serve the hand, essentially, so it's got a 360-degree movement possibility. So you've got the rotator cuff, which basically stabilizes the shoulder humeral head in the joint. As you've got four of those, you've got supraspinatus, infraspinatus, teres minor, and then subscap that sits at the front. And then over the top of that, you've got your deltoids, anterior, middle, and posterior, which are designed to primarily move the shoulder. And then you've got those muscles that help support from the scapular point of view to upwardly rotate and downwardly rotate. So upwardly rotate to elevation is upper trap, lower trap, and serratus anterior.
Mm-hmm.
And then your rhomboids, middle trap, and pec minor will downwardly rotate, so to help guide and move the shoulder through there.
Yeah.
And then just the labrum acts like a bit of a vacuum pump to help enhance a little bit more stability. But the main comes from the muscular control.
Yeah, for sure. We might jump into your assessment method. So let's talk about this as someone coming in to see you straight away with this rotator cuff related pain that they're having, and talk us, I guess, through your assessment method that you would go through with this person, and kind of referring, I guess, to the anatomy and your clinical reasoning behind, because that's, I guess, what I really like to understand is why per se those tests are done or those questions are asked of the client. And as you said, shoulder pain can be from a myriad of different conditions that you've stated. So I know this can be quite extensive, but it would be interesting to pick your brain about the specifics you go through on your assessments.
Absolutely. So when the patient comes in, a lot of time I'm going to spend is actually on the subjective assessment. And the reason is you do want to rule out, with shoulder pain, you want to be sure that what you're working with is a shoulder and what type of shoulder pain. So I'm going to be asking questions, first of all, about the history of onset. So what happened? Was there an acute incident, or did this happen over time with the change of activity, workload, sporting activity, or did this come on without any particular cause? I'm going to be talking about asking about how long the pain has been on for, whether it's 6 weeks, 6 months, a year. Does it recur with activity, or is there no real mechanical pattern? Does it just appear no matter what the person does?
And do you see is that response quite high? Like it appears without any major rhyme or reason, or is it kind of different depending on who you're seeing at the time?
It'll be much more specific to that sort of population. Would be more specific to so that's kind of mimicking what's called a frozen shoulder, or adhesive capsulitis of the shoulder, and the most common with, as I mentioned earlier, in diabetic patients, and also females between that 40 to 60 pain bracket.
Yeah.
So that's that primary frozen shoulder that just happens, and we don't know why it happens. We just know that people are a bit more increased risk, as I've said before.
So it's kind of like flags you should be aware of anyway when your client's coming in. So from our point of view as ex-phys, we need to be, I guess, highlighting that and just knowing it as a risk factor per se. Yeah.
Absolutely. And then with the vast majority of shoulder pain, you'll find that mechanical pattern. So you'll find a change in activity, either a change in sport or possibly a change in work circumstances, or a high level of sustained activity. So someone's been training for a long time. Bowlers in cricket is a very, very common one. Manual labourers, where they're working very long hours through the day. Sometimes medical technicians just having their shoulders in, prolonged positions of twisting and rotation and that sort of thing. So getting a real detailed history of the patient is really important to direct it. And then I'm going to find out things about the pain area, and this is pretty important. So I guess when I'm assessing shoulder pain, so you're trying to essentially rule out diagnosis with a specific pathology, okay? And they can most commonly include diagnosis from the neck, so nerve-related pain. So if they've got pain traveling down the arm past the elbow, presence of tingling, numbness, that it's a strong clinical suspicion of at least neck involvement.
Yeah, definitely. Yeah.
Significant night pain that doesn't involve with rest, or progressive loss of movement of the arm, as well as a real specific description of quite intrusive and distressing pain that's very common, that what patients report with frozen shoulder. And then if you're thinking other areas that can refer to the shoulder, they might describe pain after a heavy meal, which might involve a gallbladder referral, or pain with heavy breathing. So the diaphragm can refer to the shoulder as well.
Yep.
And as well as on the left shoulder, you can get some crossover with the heart and cardiac issues. So very important with someone who's got a history of cardiac disease or heart attack. Cardiac myocardial infarcts can refer to the shoulder and down that left arm, and that classic sign of getting that arm pain and a cold arm.
Yeah. So it's really it's so important to things that you just brought up there that I probably wouldn't have thought of, like pain after a heavy meal, and that referral could be interference with the gallbladder as well, or something to do that. Very good, little checklists and flags that I think our listeners can have takeaways from this as well. So, excellent stuff.
I think just the caveat on that is that it's very, very rare to have gallbladder pain. So it'd only be something that I've kind of ruled out more mechanical pain.
Yeah. But I guess, the point there is you have to be broad, and it's more ruling out, as you're saying, and covering all bases. And that's what I guess this holistic care is. And for the patient who, when they're coming in for saying I've got shoulder pain, it's not, it could be something different. It's not just going to be muscular or tenderness. It could be a referral. So I think it's
absolutely
a good reminder to go start broad, rule out, and then get into more specifics. Yeah.
100%. And then moving on to the objective. My objective is really simplified over the years. So I'm looking at their most aggravating functional task, whether that's lifting, whether that's pushing, pulling, reaching overhead, can they take their jacket off? Those things that really detail me into the subject that they're having a problem with that I can replicate in clinic. And then having a look at active range, passive range. Passive range is key, particularly passive external rotation.
Mm-hmm.
Okay, that's going to rule out a lot of specific red flag pathologies right there. So frozen shoulder, if you've got 50% loss of external rotation, passive external rotation compared to the other side, I'd be suspicious of a frozen shoulder, particularly if it's persisting. It'll also rule out things like any dislocations, fractures, anything that's blocking external rotation of the shoulder. Sometimes cancer metastases can do that as well.
Yeah, for sure. Mm.
So that's a real key one that I do, probably almost second in my objective after functional testing. And then just having a look at active range of movement and then seeing how they move. So do they really hitch at the shoulder blade? Do they lift that shoulder blade to the ear? Does their arm drop as they're lowering it? Do they compensate with low back? All those sorts of things. So they're really important to get the quality of movement.
Yep.
And then moving on to that, there's a bunch of special tests that are out and available. So empty cam.
I was just about to ask, what's your thoughts on these? Because this is something that when did we graduate, Rob? 2012. And there's the go-tos back then, but particularly for me being a bit of an older dog in body track now, the younger generation coming through are debunking these quite a lot. And I don't per se use them extensively, but I really want to hear your perspective on this, Rob, about special tests.
For sure. And look, with those tests that are really focused on impingement or diagnosing bursitis, which rotator cuff it is it the long head of biceps, they're not very valid. And the reason is because there's so many structures intertwined with the shoulders. There's about 12 bursa, which have got a lot of nerve innervation. So if you're twisting or pressing anything, you can't really tell what it is. You can tell you've got a sore shoulder, but you can't specify which particular structure you're compressing or twisting.
Yeah, cool. Whereas that's sort of where the special tests were aligned to. Hey, if the classic one was empty can, you get pain. Oh, it's impingement syndrome. That's So, and as you said, that's been a bit disproven, the impingement syndrome per se. And as you're highlighting here, it's more rotator cuff related pain or issue. So it's a knock-on effect to the special test's validity, I guess, as well, isn't it?
Yeah, absolutely. And it even goes back further that if you've got, a high percentage of people without pain that have structural issues such as bursitis and rotator cuff tears and tendinopathies on scans, then it doesn't make the test very valid in the first place. And that's what they found in research.
Mm.
So I tend to avoid those unless I'm unsure if it's a neck or a shoulder. I won't really do those tests.
Okay. Yep.
I will have a look at some very specific tests like what's called lag signs for the rotator cuff. So basically you hold someone in end range external or internal rotation, and then you remove the support and see if their arm drops.
Right.
And that can be that along with what's called a drop arm sign. So again, you lift the patient's arm up down to the side, take the support away and see if it drops or if they wince in pain. That can be signs of a massive rotator cuff tear, which might change management depending on who I'm dealing with. So if someone's had an acute injury and they're under 60, and they got signs of a massive rotator cuff tear, then they should get surgical opinion. Whether or not they get surgery is another thing, but they should get orthopedic opinion.
Yeah, for sure. And sorry, Rob, in that drop arm test, was that what position was the client in? Is that a sideline position or is that a?
Just to clarify, so in standing, into abduction. Yeah. Some papers do external rotation as well, but you'll find pretty much the same result whether you do it just in abduction or with external rotation.
Sure. Yeah. No, that's good to know. All right. So let's go on. I think that was pretty good in-depth understanding of your assessment method and some really good takeaways I find from there. Learning already about. Yeah, I think there's a key concept, starting that broad, ruling out and getting more specific, and really simplifying your objective testing to pinpoint what the actual issue may be. What's the frequency of kind of visits for these patients for you, Rob, and what does it look like at each review? So I may have jumped ahead a bit. Do you leave them with anything to from that initial appointment? Do you leave them with anything to work on? And then what's the next review kind of look like from there?
Yeah, absolutely. So picking when to do the next review really depends on the patient that I'm working with. So we know that strong predictors of shoulder pain are kinesiophobia, so fear of movement, and also self-efficacy, so someone's belief in the ability to do a task in the presence of symptoms. So if both of those are really high, I'll probably see them within a couple of weeks, so 2 to 3 weeks, just to really re-emphasize the education and basically hammer home any messages based on movement or review the exercises, etc. I think coming from
sorry, I could jump in again, but it just on that too. Like how do you, I guess, go about identifying that necessity or like kinesiophobia or self-efficacy? Is that straight up questioning you ask, or is it what you're picking up in how they're presenting, or?
Yeah, so it'll be a bit of a hunch to start with. You might hear them talk about their pain and it might talk very threatening. They might have unhelpful beliefs about their pain, like they might come in and, because usually most patients will come to me with a scan because they're referred from the consultant. Yes. They might be very worried about their scan unnecessarily. They might have been out of work for a while and might detail the fact that they might be afraid of going back to work or not being able to go back to work. So there's points in the history and discussions. I might ask them, what do you think is wrong with your shoulder? What do you think you need to get better? They might straight up say, I think I need surgery. So those things are really pricking those areas. And then there are validated outcome measures as well. So I've got a pain self-efficacy questionnaire, Tampa scale kinesiophobia, which can use as a bit of validated measures with that.
Right. Yeah. Good to know.
And then back to the visits. So I'll see someone early if they've got low self-efficacy and higher rates of kinesiophobia. With a lot of the patients, specifically with rotator cuff-related shoulder pain, they're probably going to be more persistent chronic patients. So as you know, in an exercise program, you want a minimum of kind of 3 to 4 weeks for exercise to really start to build some neuromuscular change.
Yeah, indeed.
So that could be an ideal frequency visit. And then as to what that visit will contain, it'll revisit some education that we've delivered in the previous session. So whether that's talking about what rotator cuff related shoulder pain is, what are some improvements that you might have felt. We might use what's called a patient-specific functional scale, where they rate an activity that they're having trouble with, rate their ability to do it out of 10. And I might ask, what's that number this week? Have you noticed any change? So that's both a specific and valid way of measuring patient improvement. And then reviewing the exercises and see how well they can do the exercise and progress from that, because exercise is a mainstay treatment for both experts and physio when dealing with these patients.
Yeah, indeed. And I guess what's that exercise prescription look like from your perspective? Obviously, it's going to differ depending on what the actual issue is. But if we just focus on that rotator cuff related pain, what's is there any specifics that you might go to? Any kind of exercises that you start them off with, and then progression plan from there as well?
Absolutely. So each of the exercise programs that I use these days is kind of reverse engineered from their painful functional tasks that they've discussed with me. So let's say it's reaching into a top shelf. So the aim is to be able to improve elevation. And there's certain ways that you can tweak an exercise program to help achieve that. So some real go-to ones that I can do is like a wall slide with a bit of resistance.
Yeah.
And with a wall slide, any kind of what's called closed chain, so when your hand is pressed against a solid surface, we know that increases activity of your scapular upward rotators.
Yeah.
So that's a really nice one to use, particularly initially. And then using the old trusted resistance band, tie it around both hands and then push up as well. We know that starts to activate the rotator cuff, the posterior cuff a little bit more as well.
Yeah.
So those two can be very useful to help improve someone's confidence with movement and are directly relatable to their activity. And then really building capacity in the shoulder. So not just the rotator cuff itself, but capacity itself. So going for really reliable basic ones such as rowing type exercises, so things like bent over rows, chest pressing, carrying, even just simply carrying the arm in one side, so using a shopping bag, dumbbell, any kind of bag at home, and progressively building that load can be very, very important.
Hey, thanks for taking the time to listen to our podcast, and we hope you're learning a lot in this particular episode. Just a shout out to our sponsor, HGG Performance, which provide very high quality, innovative gym equipment and custom fit outs to enable you to pivot your potential and smash your performance and rehab goals. They are world renowned for their innovative creations in the gym accessory space, including the best-selling ISO Tib LT, Tib Bar, Wrist Axe, and Nordic Bar. And I got to say, we're using some of these equipment in our clinic and finding some great results. Used by professional sports teams, athletes, and coaches worldwide, as well as the military, health practitioners, and apparently even Joe Rogan uses their gear. HGG is a proudly Aussie-owned company that makes all their gym equipment at their Gold Coast HQ. And our partnership with them, we are stoked to offer you 10% discount on any product with the code BODYTRACK10, so you can experience what all the hype is about yourself. So jump over to their website, go to the checkout, punch in the code of BODYTRACK10 to get 10% off on any of their great innovative gym equipment, and start using today. Thanks very much.
And on that too, like, there's a lot of kind of, I guess, focus on whether mobility, range, strength, and how you're kind of starting with it. Now, from my understanding, my prescription, I would go for a combination of all three. In your perspective, and you're looking at how a client is progressing, are you looking at a combination of those three progressing, or is there something that you need to stand out? Is mobility come first, or range? Like you were mentioning about active range and passive range, is that kind of some things that need to be ticked off first to then further progress with strength training? Where does it kind of sit at the moment for you, Rob?
Yeah, I certainly wouldn't attack one and then the other. The reason is for most of these patients, they'll have pretty good active and passive range. It will just be painful. You might have a little bit of reduction, but most of it will be there. The other thing as well is considering what can contribute to reduced active and passive range can be things like muscle guarding and muscle weakness as well. So if we just focus on stretching without addressing strengthening, your time to improvement can be much more drawn out. So I start things like strengthening straight away, regardless of what their range of movement is, and just working within what's comfortable for the patient in terms of their range.
Yeah,
that's
great to know, because I think that's what, particularly in terms of clients and how they're presenting as well, they sometimes it more goes towards like this kind of static stretching that they feel they need, and they think like by stretching it and getting that range, then they have more function. But it's good to hear from your perspective, like you're still starting with strength regardless of what range they're presenting in. It's just within that pain, that range that they have, isn't it? And making sure you can build your capacity through that. And it's all, as you said, reverse engineered from that key goal of what they might be wanting to achieve or what they're limited in with their activity of daily living, such as that push into an overhead cupboard or something.
Yeah, absolutely. And I think it's really important, and as well as it harnesses also the other effects of exercise and strengthening as well, that are more like building confidence as well. We know that exercise and strengthening has a hypoalgesic effect, essentially from the brain. So it taps into all those others as well. And your stretching, it's got a short-term effect only, and it can be quite uncomfortable without that extra benefit. So it's much more beneficial to start strengthening within your patient's capacity as early as the first session. We do set some guidelines for pain. So pain is an important guide with this. So nothing more than a 4 or 5 out of 10 pain, or a pain that is manageable for the patient but doesn't cause them to stop. So that moderate level. And it should be settled by the next morning. So that's kind of guidelines for tendinopathy in general. Yeah, but we can apply those definitely to shoulder pain as well.
Yeah. Just want to pick your brain a little bit on, I might be going a little bit off topic of the shoulder, but just in general, your perspective on like static stretching at the moment for improvement of symptoms, right? I'm going to be out on a limb. I've done some research on it, and I see that it provides some immediate relief of a painful area per se, but the long-lasting benefits. So if it's something that you're prescribing and doing, as a prescription, and getting them to do it daily or every second day, from my understanding, I don't believe it does have long-term outcomes unless you are backing it up with your strength through range. Am I right in thinking that, or is there some thoughts of my process there to be debunked?
No, I think it's absolutely spot on. I think that's my interpretation of the literature as well. Because when you have strengthening, you just have much more sustained muscle fiber change. So as you know, you've got a bit of hypertrophy, and you've got more muscle sarcomeres in series, whereas stretching, it's relaxing of the Golgi tendon organs and muscle spindles that allow a bit more elasticity to the muscle. But as you said, very, very short term. In isolation, I can only think of, if we're talking about the shoulder, maybe a frozen shoulder that's very, very stiff. Loaded static stretching. So having a dumbbell in the hand and letting it go out into external rotation, that's probably the only time I use it with the shoulder, to be fair.
And see, that's still the thing though. It's still loaded though, and you're still getting that benefit.
Yeah, exactly right.
Not just a static stretch. Yeah, for sure. No, that's good. That's solidified my thinking too. So that's certified by Rob the physio. No, that's great to hear. Now let's kind of go towards the end of the journey for this client that you might be seeing. What does that sort of look like? When are you happy to go, yep, I'm ticking off that you're good to go back and participate in these activities? I mean, it might not always look like that. It might be, no, we need to get to surgery for this. We've tried the conservative approach that hasn't worked. When are those scenarios happening, and what triggers or red flags or yellow flags that we look out for in those situations?
So it's a really, really good question. And so first of all, it's going to start from the goals of what the patient wants in the initial assessment. So is it, let's go back to that lifting over, reaching into the top shelf again. Actually, let's go something a bit more vigorous. Let's go, working as a carpenter. So a lot more loaded activity and a lot more prolonged activity. So there was a study called the GRASS trial done in 2021 over in the UK that said the most cost-effective method was physiotherapy plus shoulder injection,
right?
At about 8 weeks. So we know that if we get someone in early with an injection, corticosteroid injection, about 8 weeks, it can have a good window of opportunity to progress your rehab.
Right. Yep.
Then, if someone's going really well, I'll relate back to their goals and that patient-specific functional scale. Have you had more than 3 points of increase on that scale to be significant? And that's a good indicator there. Is their pain much more manageable? Do they not get that pain after the day? Is their pain intensity reduced? Have they tried a progressive kind of going back to work, and have they passed that? That would, all those points lead me to think that this person's right to go.
Yeah.
However, if in about 3 months they're really not improving at all, even in a small amount, I'll just be having a chat with my orthopedic colleagues. They've probably got a review lined up with them anyway. But 3 months, you should start to see some improvement with your shoulder pain.
Okay. Yeah, that's a good time frame to know, because we do see a lot of shoulder pathologies here, and very prolonged. But in our model, we see people quite regularly, right? We see them weekly. They use it as, I guess, their health and well-being for sessions during the week. But they are carrying, per se, like a shoulder injury, and it can be quite prolonged and never quite linear, the progress. It can be undulating of affected days, etc. But I've always caught myself of going, okay, how long is too long to leave it before, say, further intervention of physiotherapy or orthopedic review or cortisone injection? Cortisone was actually one I was going to pick your brain about as well, because, and correct me, but I think you said earlier, intervention of a cortisone followed by physiotherapy is the best outcomes from that trial. Is that correct? From that study, sorry?
Yeah. So we know that cortisone, for a particular patient, it can be beneficial in the short term. It needs to be coupled with exercise to be better at 12 months.
Yeah.
You can't use injection on its own and expect to get better.
Yeah.
But you don't want to do too many of them as well. So I think over here we limit them to about 2 or 3. Because we do know it has some side effects on the joints and tendons and things like that.
Yeah, of course. And I think that's the difference, because I've had clients for various different reasons of presenting with different pain, perhaps hip, shoulder, elbow even, that they've had cortisone, but I don't think they've actually coupled it with strength training. And that's sometimes we get them that they've had 2 injections and they go, well, it doesn't work. And I've explained it and gone, well, have you done exercises with it? No, I've got some exercises to do and I never did them. And I was like, well,
there it is. Yeah.
So then you're on that kind of the precipice of, well, I had their second injection and it's a shorter time frame. Do you go to that third to then still get strength and including with the session? So it can be somewhat of a fine line there, I guess.
Yeah, it involves a real cohesive approach between yourselves and the orthopedic consultant, but and really hammering home that expectation with the patient that if you're going to have this injection, you need to put in the work afterwards to be able to get the effect or the desired effect from it, and still keep that strength and robustness of the joint and the tendons.
Yeah, of course. No, that's a really good take-home message there, Rob. Hopefully cleared up a bit of conjecture around cortisone injections and how they work with strength. But it's good to good to have that recent trial and to show the effects of cortisone with strength-based to come back and have the best intervention there. Okay, so I think we've covered basically where you can almost discharge them from your care, but what does that discharge look like? Are you recommending continual exercise? Do you refer on to other like allied health, or is that something that you can do in your role? How does it kind of look from your perspective?
Yeah, so with the confines of the NHS, unfortunately, we're not really able to refer on to any others. I think exercise physiology is not really in the public sector; it's more of a private thing. So if if the patient has the ability to do that, then absolutely we're going to be doing that, because I really try to encourage my patients to get into the gym and start to load up exercises as well. And you guys are the best place to do that. So I think that's a really important thing to do, because yes, ongoing exercise for a myriad of reasons, for shoulder strengthening, keeping up their functional tasks, general health, mental well-being, it's something that we really, really press home hard with our patients. So at discharge, it's an ongoing exercise program / routine. As you probably know, it's a lot of behavior change that goes on with getting someone to start exercising regularly. So that advice and education to go on how to plan their week with exercise, how to know when's too much or when to progress, all those things that help come into that real load management aspect of discharge. And I think that's about it.
Yeah, fantastic. I think we've covered quite a lot here, Rob. I mean, we could talk about shoulders for another couple of hours, I reckon, but we both have things to do. And I just was going to wrap it up, and if you can give a couple of take home messages for what we discussed today, top 3 perhaps that you have as a take home message for our listeners.
Yeah, fair. So I think the first one is, when someone comes in with shoulder pain, it's making sure you're dealing with a shoulder, and just be mindful of other areas that can refer to the shoulder, neck, visceral pain, and any other sinister pathology. The other one is, I think, keep it simplified with your patient. Focus on what they want to achieve, and measure that appropriately with outcome measures or patient-specific functional scale. Exercise, absolutely really important. Give it time, give it a good 3 months, particularly if someone's got shoulder pain, and keep it progressive and something that they're going to be able to continue on with long term.
Fantastic. I think that last point really hones in well with ex-phys as well, is giving it time, because a lot of clients will come in and expect quick results, or they do get, that, and they may not have been exercising prior to seeing you, and they do see the change happen quickly. And like I was saying before, sometimes it's not always linear. Sometimes you have some setbacks. And so just laying it out and being really clear the expectation of how long this can take, and that it can be a bit up and down rather than always improving. Through the
that's a vital point. That's a really, really vital point, isn't it? That's a fantastic one.
Well, Rob, I appreciate you getting up early in the grey skies over in the UK. Hopefully this enlightened your morning doing a podcast.
Absolutely, mate. It's been an absolute pleasure. Thanks for having me on.
And look, I'm sure we'll get you back on again to talk about a different joint in the body, because definitely I've learnt a lot, and I'm sure all the listeners will be really, really appreciated. So thanks for your time, Rob, and we'll talk again soon.
Pleasure, mate. Thank you.
Thanks for listening. We hope you enjoyed this podcast, so remember to share, like, or follow to keep updated with all our podcasts and educational resources.